So this is the kind of bacterial spirochete protozoan chapter, mostly bacterial stuff, of course. And this first case is Lepromatous leprosy. And so from scan, there's a skin piece here. Scan, you can see that there's this lymphohistiocytic infiltrate with, even from scan, these conspicuous little holes, these little collections interspersed throughout that infiltrate that make it look a little bit odd. And so immediately you kind of start to think this might be something infectious. Maybe if it had a slightly different appearance, you could also reasonably say, well, could this be some sort of exogenous substance, filler or something? But there's just too much of a mixed infiltrate pattern. And then, so getting in a little bit closer, you see that sure enough, there's all these little holes here, and they all seem to be filled with this kind of amphiphilic material. And there's not a whole lot of other stuff that does this. Now, it certainly would make you think of the infectious realm, and in this case, of course, it's leprosy. You'd want to do a full panel and stain for things, but that would include a fight stain or something for acid-fast bacilli, and that's what the next slide is to show it. But this architecture with these little holes, you could kind of see something like this with Leishmaniasis as well, which there's a case of that later on. Of course, that would be littered with really, really tiny organisms, which then also fill little holes. So, there's other things that the other infectious things can create that sort of picture. But if you're not seeing actual organisms, you're not seeing, histo or crypto or fungal things or leash, and instead you're just seeing this sort of amphiphilic material, then that's where you really start to wonder about leprosy. And so if you do a stain, all these, like a fight stain, all these would turn brightly red. You can see here, there's just that sort of granular material. All that is organisms. Now this is, Lepromatous leprosy is the multibacillary form, and so you do see lots and lots of organisms. But in the more tuberculoid form, you really find hardly any organisms, and then there's a lot of stuff in between. So here as well, this other cut, there's lots and lots of organisms in here. And this is just chock full of kind of a mixed infiltrate. So there's lymphocytes, there's lots of histiocytes, there's also plasma cells. You can see here, maybe you'd find the occasional eosinophil or something. But so that is Lepromatous leprosy, and then the next slide.
Those are globi, Justin?
Yes, those are the globi. Those large kind of vacuole collections of organisms. And so, looking at the stain here, you can really make out, all those bright red organisms there. And then you get a little closer, you can kind of almost make out morphology. All these little globi, little organisms, and there's organisms, kind of diffusely spread throughout here, but there are in these little globi collections. Almost comes up better on the TV screen, but so that's a very, very, very positive stain. You won't have you could potentially see no organisms, or maybe just like one or two in tuberculoid leprosy. So this next case, this is number 2. This is Ecthyma gangrenosum, and there are some, in the derm world, we think of just run-of-the-mill ecthyma, and anything with Ecthyma gangrenosum, and so there's multiple organisms that can create a similar picture. When we say Ecthyma gangrenosum, we really mean, typically we mean that Pseudomonas infection that's causing kind of a deeper necrosis of vessels. So from scan, it just looks like there's, some probably a lymphocyte, largely lymphocytic infiltrate. It's kind of perivascular, but it goes pretty deep. And then there is a lot of pink too, and so you wonder, is it fibrin, is it red blood cells, is it necrosis? And as you get a little closer, you start to see that it's definitely a mixed infiltrate, and it's kind of focally around some entities, vessels and whatnot, but it's also diffuse throughout the dermis, and particularly deep dermis. And there's just sort of this grunge appearance to it. And let me find, there's a cut over here. Let's see, where's that at? Here, you can start to see that when you get this sort of homogeneous pink look down here in this deep dermis area, I mean, all that's just necrosis. And so it just doesn't look right. It's got this sort of smudgy appearance to it instead of the nice, well-organized collagen bundles. You got this kind of haphazard infiltrate that's not it is perivascular up above, but down here it's just sort of all over the place, and it's a mixed infiltrate. There's going to be a lot of lymphocytes, but then also neutrophils and some charectic debris in here. I'm sure there's histiocytes and maybe even some eosinophils in here. But then what really makes the diagnosis is when you start to look at these vessels again, which hopefully you can see that. I mean, they're almost hard to see because they're not well defined, because they're so necrotic. So from the necrosis, they're kind of dying off, and they don't look like obvious vessels. But these vessels here are they're turning into that pink schmoo, that homogeneous appearance. These are all necrotic. And then right around the vessels, you see this very faint, sometimes hard to see, but this very faint kind of blue haze. And all those are the organisms. And if you did, a Brown and Brin or something, I mean, those would all stain. You'd be able to see those a little bit better. And getting in is a little bit closer, you can kind of make those out. Just that sort of faint bluish haze, and that can be hard to really focus in on. So that one is Ecthyma gangrenosum. Okay, number 3. This one is tuberculoid leprosy, so paucibacillary form, and usually from scan, and we see the skin, the epidermis, and you see what appears to be you're thinking, oh, maybe this is like a perivascular infiltrate, and but it doesn't look quite right. It doesn't look like lymphocytes per se. There's a lot of cytoplasm, so you're kind of thinking more histiocytes. And then as you get closer in, you say, sure enough, these are more tuberculoid granulomas that are kind of following nerves and vessels, but particularly nerves. And so when we talk about like the sausage-shaped, particularly kind of left to right tuberculoid granulomas that are following nerves, that kind of speaks, tuberculoid leprosy. Now, a few other things can look like this, mainly syphilis, of course, can look like anything, but there is like a tuberculoid syphilis that can sort of look like this. But really, when it's these, somewhat pretty well-defined, tuberculoid sausage-shaped horizontal granulomas running along nerves, that means tuberculoid leprosy. And you may get, some plasma cells. You may get some, other infiltrating here as well. But it's mostly just these, large and lots of cytoplasm, large histiocytes that are kind of running along, what is likely a nerve in this case. So that's tuberculoid leprosy. Now this one is Hidradenitis suppurativa, which we kind of think of as that's sort of in the acneiform chapter, but it is sort of infectious as well. Now if you really had to classify it, it would be more in kind of an inflammatory box, because it's mostly a host response that's creating the clinical appearance of the double comedones and these sinus tracts and just all the inflammation. But there is bacteria that plays a role, and so the point of this slide is really to show that kind of like acne keloidis nucae or some of these other conditions, that they're not necessarily a true infectious entity, but they can look very, very infectious. And so you might go on this ridiculous bug hunt throughout all of this infiltrate here, saying, oh, could this be crypto or some sort of fungal, deep fungal, or something weird, when in fact all it is Hidradenitis suppurativa, is probably from the axilla of someone. And so it can be a little bit confusing. One thing that may help a little bit is that you don't really have true, maybe a little bit over here, but it's not a classic pseudoepitheliomatous hyperplasia. Now some of that you can get just from the chronic inflammation. And you would still want to stain this. I mean, if there was a question, you could certainly stain it and kind of go through it. But what you're really just going to find is bacteria and all these kind of microabscesses, formation, and it'll be chock full of neutrophils. But you won't find any other infectious entity. And a lot of times it will be sort of more round follicles that are kind of dilated because it's sort of a suppurative folliculitis. All this is just tons of neutrophils and debris and whatnot. That one is Hidradenitis suppurativa. So this is Leishmaniasis, and this is a great case of Leishmaniasis, meaning that it has, you can really easily see all the organisms, but it's not always the case. Sometimes you have to search a little bit. Now, in this particular specimen, you can see why earlier I had mentioned leash when there was that case of Lepromatous leprosy with globi, because from scan, you're just seeing this sort of diffuse lymphohistiocytic infiltrate, but then you do see some little tiny holes and little vacuoles, and but even from here, they don't quite have that sort of, they're not containing that kind of vague amphiphilic material. And then as you get in closer, you still might be thinking that, but and so as with any bug hunt, you have to get down kind of on your hands and knees, so to speak. But in this case, from this altitude, you can start to see that there's granulomas forming. There's probably some giant cells in here, but it just this whole slide kind of speaks something infectious, particularly with all these little vacuoles. And so you want to get down and investigate that. And so now, at this magnification, you can start to make out all these little tiny organisms. And again, they almost come out better on the TV screen, but all these little organisms, and it brings up a differential. So it's the parasitized histiocytes differential, and there's some plasma cells in here, some lymphocytes, of course, tons of histiocytes. And you may have to do some stains to differentiate it from histoplasmosis. You can look for the marquee sign, which is helpful, but it's not necessarily pathognomonic. But that marquee sign is where the organisms kind of line up around the vacuole. So instead of being, let's see if I can find an example. Instead of being interspersed evenly kind of throughout one large vacuole, they sort of line up right at the periphery. Get this in focus. So maybe you can see a little bit here that there's they're more lining up around there, like a marquee sign or one of those old signs with all the light bulbs around the periphery. So again, that can be helpful, but really when you just see all these super tiny organisms, you're thinking leash, but you want to make sure it's not histo and some other fungal organism. Of course, leash is in the protozoan category. Some people say, well, you can try to look for the whole kinetoplast and stuff. That is, very challenging, and sometimes it's better to do with stains, or easier to do with stains. But so that is Leishmaniasis. So this one is your classic case of syphilis, and I wish all of them looked like this, because this really, when you look at it, it can't really be much else. And one of the biggest clues is that anytime you see two predominant patterns that are kind of in the same specimen, that really should make you at least think a little bit of syphilis, and ever more so when it is interface combined with psoriasiform. So that's what you have here. Usually an interface dermatitis or vacuolar, lichenoid, some sort of interface dermatitis usually over time produces effacement of the reedy ridges and not this psoriasiform, and in this case more the slender psoriasiform hyperplasia. So when you see those two things together, that all this infiltrate that's kind of creating a little vacuolar interface dermatitis that's then combined with this psoriasiform kind of slender hyperplasia, that really makes you think of syphilis. Now there are other clues, newts in the horn. That's why it's on the newts and horn differential. And you can see there's some little newts up here in the horn, and so you want to think of the whole Petrix thing, which includes sebderm and syphilis as the two S's. And then you might see tons of plasma cells. Plasma cells can always help a little bit, but that also may just be the location. So if it's a biopsy of a canker on the genital region or something like that, it could just be location. But usually there are lots of plasma cells. And then what Dr. Elson likes to talk about too, and he's done some studies lately, with some residents and whatnot of some of the other findings, the histological findings that can be helpful. Endothelial swelling can be very helpful, to where it almost looks like you can't even see the vessels, or as if they're occluded, because of that endothelial swelling. It's hard to make out the lumen of these vessels because of that endothelial swelling. Now, over here you can kind of see this vessel, but those endothelial cells are pretty swollen, and I'll get down a little closer here in a second. And then the other thing is that the lymphocytes almost look like histiocytic, so they're a little bit atypical. Not atypical in the sense of mycosis fungoides, but atypical that have a little more cytoplasm to where they almost look like histiocytes. And there are histiocytes in here as well, but it just makes the infiltrate look a little bit odd. But those, when you combine all those different features, it really makes you think of syphilis and really should prompt a stain. So here, there are some very tiny little vessels in here, but you can't even really make out the lumen. I mean, maybe that's a lumen there, but the endothelial cells are so swollen. And that isn't exclusive to syphilis. You can see that in other things, even under a tick bite or whatnot. But that is just further suggestive of syphilis. You might see some fibrin and some ulcer development, but it's really that combination of the interface, in this case, plus the slender psoriasiform hyperplasia. So you want to stain that. And actually, I'll kind of jump to 13 and 14, although I'll probably just do 13. 13 is a Steiner stain. I don't think it's the same case. But Steiner stain is fine. It can be very hard to find the organisms, though, so it's not perfect. And then you also have to be careful not, that the silver stain will stain the dendritic processes of melanocytes and typically, I think, also Langerhans cells. And so when you see all those squiggly dendritic processes, they can almost look like spirochetes. And so you have to be careful not to overread something. You have to look for the very, very, very tiny, which I'll point out here in a second, very, very tiny little squiggly spirochetes. And so nowadays we like to really use the treponemal stain, more of an antibody stain, which is much easier to read. But it, of course, isn't perfect either, and sometimes it can be negative. So over here, for example, all this dark stuff is, that's probably melanin, and then in there that you might see some dendritic processes. So those aren't spirochetes. That's not positive. That's just background noise that you have to kind of not think of. The true spirochetes are almost like this gray, vague appearance. These are probably more actual spirochetes. Yeah, so these are actual spirochetes, and you have to get down really close to see. That's what all these are, all these little organisms. So this one is chock full of them, but sometimes it's not this obvious. It's hard to to find them, and they can be very, very vague. But that's what all these are, all spear shits. I was on 60x. So that's why you have to be careful if you get the slide and you can't see all that darkness and like, oh, that's positive. That's not what you're looking for. I actually won't put up 14. It's of the GI, supposedly GI. So you'd be thinking, H. pylori. I looked at it earlier. It's a little bit hard to find those. Okay, so we were on 6. Now we're on 7. Okay, so this one is just supposed to be impetigo, and the trouble with impetigo is, is the what you're seeing, the organisms, is that the primary process? Is that what the clinician wants you to find or need help diagnosing, or is it just secondary impetiginization of whatever else is going on? So in this case, it's read as impetigo in like a scale crust. And obviously, you can see all this. This is the scale crust that the clinician is seeing, full of serum and some inflammatory cells. And impetigo can be bullous. This isn't really forming true bulla, but you can get bullous impetigo. And then what you see here are the organisms. So all these little blue collections. This is the staph organisms that's causing the impetigo, that honey-colored serum crust that we see clinically. And so that is the impetigo. So those are little colonies there. Okay, this one is pitted keratolysis. This is number 8. And they're not always this awesome in terms of their the dell that you see that's in the textbook. So here you see a very obvious kind of dell that's here in the thickened stratum corneum. And this stratum corneum is not thickened pathologically. This is acral skin, so it's kind of normal hyperkeratosis that you'd see, or just normal thickened stratum corneum you see in the acral location. And so that means it speaks to an acral location, and you see this dell, and then when you get in closer, you see organisms, and all that when combined basically means pitted keratolysis. If it was a non-acral location, you kind of saw some organisms that were filamentous, and especially if they're vertically oriented, that makes you think more erythema. Pitted keratolysis is caused by Chytococcus and also Corynebacterium. So here are the organisms. Try and get them on the screen. Okay. So you can just see there all the organisms. That's the pitted keratolysis. Okay, number 9. So this is another Lepromatous leprosy, and this one, there's, maybe there's some in between. There's not as many of those little globi, little vacuoles, and there's some areas that are almost a little tuberculoid. So maybe this is kind of an in-betweener or a borderline lepromatous. I mean, there's a whole spectrum, of course. And but from scan you see kind of this Gren zone, you see this sort of diffuse lymphohistiocytic infiltrate, and then there are some little vacuoles in here that you want to get down and investigate, and in those vacuoles are where you see organisms, particularly if you stain it. And that's what a lot of these little vacuoles are. And you have to be careful though, because some of them, may actually, you could see some organisms in there, whereas others may just be more from kind of the chronic inflammation that's occurring. So, there's you definitely would want to stain this, but it is a mixed infiltrate. There's some EOs in here, and just kind of has that infectious look. So you kind of want to go down, what sort of infectious things can cause this sort of appearance. And Lepromatous leprosy is certainly one of them. Okay, this, number 10, this is Rhinoscleroma. And, from scan, there's usually just this, pronounced diffuse infiltrate. And for whatever reason, Rhinoscleroma in particular often forms these sort of crack-like spaces, and that can be a clue. And you can see that in other things too, where there's just chock full of inflammatory cells. But it does seem to go fairly well with Rhinoscleroma. And then you see some of these little kind of holes in the infiltrate, and those are more than likely the Micolic cells, the ones that contain the actual organisms. But obviously, when you see this huge infiltrate, you want to get deeper to see what exactly is going on. What are these cells? And then when you get in closer, you find that most of them are plasma cells. But there are, histiocytes. There's some neutrophils with keratolytic debris. Kind of makes you think, something infectious. And then again, you do see here's a pretty classic Micolic cell with organisms within it. But you also start to see Russell bodies, and Russell bodies are these sort of swollen or so-called pregnant plasma cells. Usually they're easy to see in this kind of sea of plasma cells. You can note the sort of pink swollen Russell body that's just full of immunoglobulin. And there's other types of cells too. There's Mott cells that are when you have a kind of a Russell body that's got more aggregation, like aggregates of little cytoplasmic inclusions, and then there's Dutcher bodies that you see in other. These are other types of alternate plasma cells. You don't really see those with Rhinoscleroma. What you see in Rhinoscleroma are the Russell bodies. But if you hear those other bodies being talked about, the Dutcher bodies and Mott cells and stuff, those are other sort of variations on plasma cells. But in Rhinoscleroma, you're seeing kind of this infectious background, lots of plasma cells, and then Russell bodies. And these are for like first years who are still trying to know, what are plasma cells. These are always good slides to look at because there's just tons of plasma cells all over that are pretty easy to see. That's that one. And that's caused by Klebsiella. Okay. So this one was listed as Erythema nodosum leprosum, and that's the type 2 reaction to leprosy. And from scan, you have this infiltrate that's perivascular, but also deep, kind of in the sub-Q. Also, almost in the fascia, you have some thickening of the fascial layers, as well as I'll get a little closer in, but you can almost see from scan there's something going on around this entity, which is a nerve, and that's the onion skinning fibrosis that occurs. So the whole specimen kind of speaks of something infectious that's maybe been going on for a while, so more of a chronic thing. And Erythema nodosum leprosum is kind of this leukocytoclastic vasculitis that's superimposed onto leprosy and sort of the lymphohistiocytic, and sometimes a little granulomatous reaction that you get. And so, up here there might be some faint findings of classic leukocytoclastic vasculitis, but it's more of a chronic LCV. So kind of like granuloma faciale in a sense, you may not necessarily see an obvious vasculitis, and instead you're going to more see the chronic changes, and it's most notable around you get those changes around vessels, but also around nerves, because that's where a lot of these organisms are attacking. And so it's more around this nerve where you can see that kind of onion skinning fibrosis, in the background of just diffuse mixed infiltrate. And you can sometimes see, depending on what end of the spectrum you're on, you might see some globi and organisms, and stain might be positive. Here you're seeing more of just tons of giant cells. in this location, but you did still want to stain this. And usually the patient would have a history of leprosy, but it still would be something to think of if they don't. And then this last one, number 12, this one was listed as the type 1 reversal reaction. And so this is where someone is more on the lepromatous end, and then they get treatment and they get kind of an upgrade in a sense to their cellular immunity, and so you get more of this robust lymphohistiocytic infiltrating response that they didn't really have before, and it creates, it's particularly around nerves, you can get paresthesias with it and pain and whatnot. And histologically, it's not a whole lot different than what you normally would see, except it's just a little bit more robust. So particularly on the lymphocytic ends, you're just getting a little bit more robust response to around the vessels and nerves where all those organisms are at. And you may start to lose some of the organisms as that cellular immunity starts to kill them off. But usually there's still some globi remain and can be found with stains. So there's nothing really else like unique per se that I can speak to on this slide that would help point out the reversal reaction. And that's it.
Thanks.
Sweet. Thanks.